the proud privilege of introducing none other than Chee PHAIK, for whom India is her second home, number one. And whatever, publication you are trying to publish, you find that she has already done work. So that is something, which is, so motivating to see her around. So over to Chief to put across suturing the bag in subluxated lenses.
So thank you very much for inviting me. And what suture material do we use when we want to suture the lens? So we know that polypropylene actually biodegrades 5 to 10 years after it's used. 9.0, it may not last because there have been reports that it's broken even at 6 years. And what I prefer to use today really is Gore-Tex suture. This is actually 7.0 caliber. It's off-label use for scleral fixation, but it's got excellent longevity. We can use polypropylene 6.0 for the canberra flange. So a lot of people have seen this technique but do not really understand. So let me just give you my concepts for how to actually use Gore-Tex suture without using the needle, which is really short and thick and not meant for ophthalmic use. So if you have a CTS that's already loaded with a Gore-Tex suture, how do you bring it to the fixation point at the sclera? So if I had a needle that's already loaded with a suture and I extend a loop to act like a lasso, I can easily feed the end in for the suture, and by pulling it, you can see how we can lasso it to the scleral fixation point. So this is threading it in to the needle, and what's important is, as you can see here, you must have everything dry. You must grasp with your fingers, not the forceps, because it will flatten that suture and you will not be able to thread it in. And you cut it on a slant so that it goes in easily through a 27 gauge needle. Now when you enter at the sclera, I like to go 90 degrees perpendicularly so I know exactly where I enter. You want to go actually horizontally. Once you've entered, push down on the capsule if you're doing a fixation with a CTS there, and then pull back the needle to free a loop, and that actually helps you to get your Coughlin hook. You see, I pull back and then there's a little loop there, and your Coughlin hook can easily pull that out. Okay, so that's how you use this device, which is very cheap. Okay, so let's have a look at some cases. This lady had a fall, and you will soon see that actually this lens is decentered, and it's actually a Restore +3, and she wanted to keep that, obviously, because a fellow eye had a similar lens, and I'm just creating a Hoffman pocket where I felt that the lens was most decentered, and there was the best axis to actually place the suture to reposition this lens. So one loop of one suture is through the back complex and the other goes above. All right, you can do it one in front of the other, and I usually fixate about 2 mm posterior to the limbus. So it's gone through a Hoffman pocket, and the pocket needs to be at least half scleral thickness, and we're now hooking out the suture from the pocket, and then you throw a 2-1-1 knot. When you're doing a 1-point fixation, you need to tie a little tighter because the knot actually will fall back into the pocket, and you will have a slight decentration if you titrated it inappropriately. But you'll see that this patient had a very well-centered lens after that. Now this is a patient where you can see now the lens is dangling. Yes, it's a CTR with a toric lens. Okay, so I've marked the toric axis already. And after doing vitrectomy, you can see this was almost floating in the vitreous cavity. Clear all the vitreous, very important. Triamcinolone that's diluted. I usually use about 30% dilution. That helps to ensure a complete removal. And then having created the Hoffman pockets in that axis where her toric axis is, I come through the capsular bag from posteriorly and then draw the suture through. And now this other suture goes above. All right, so you have a belt loop around this complex. You don't tighten on it, and you just do hand over hand transfer to the other side where you can see the toric alignment marks, and that's how I want to get this well centered, all right, matching those marks with my axis. So you do the same for the other side, and then this one goes above the complex. So this is really quite minimally invasive, just 2 paracenteses and 2 Hoffman pockets, all right? Make sure you have no vitreous there, and then retrieve your sutures. You don't tie it yet until you've centered the IOL, so it's a 2 and not a 3-1-1. You don't tighten down because when you do on both sides, you don't really need it taut, all right? You just need it symmetrical so that when you put it back there, you can have perfect alignment of axis and a vision is restored. So you can do a similar technique with Cana Brava, but in this case, you don't need a knot. So this is a patient with a single piece IOL that actually dropped to the back of the eye, and my retinal colleague actually brought it up. And you can see it's a similar concept of a belt loop suture, but the way we do it is first to just use the needle and then thread the suture. And actually, I can thread it in my fingers. I can direct it more easily from externally. I just thread it through. You can see my fingers doing the work. And you do it for the other side as well, all right, through the capsular bag complex, just at the angle there so that you're symmetrical. And just use your fingers and thread this segment of 6/0 polypropylene suture. I always flange it in case I accidentally pull it out. So in this case, there's no Hoffman pocket. It's going through the conjunctiva and sclera, full thickness, and I just do one in front of the other around the 2 mm point posteriorly, and then clear vitreous, do a peripheral iridectomy, and then flange. But you need to make sure that the flanges are actually buried deep to the tenons. Okay, so just the last case, this is a patient that's complex, and sometimes we want to do minimal surgery. In a case like this, has had 2 grafts, and this one is about to fail as well. A tube there, the iris is tattered and torn, and you can see that this lens is now dislocated. And in addition, it's a single piece PMMA. I don't really want to take it out through the cornea. Right, so what do we do? I want to do minimum. I want to make sure that his graft lasts, especially when he's the husband of an ophthalmologist. So, you know, she's going to check on him every day, count the cells every day. So this is a PMMA lens, okay? It's still actually one in the bag and one in the sulcus. So I managed to just take it out of the bag and rotate it in front of the rest of the capsular bag. And again, after having rotated to this axis so that I don't have to go to where the tube is, all right, I'm going to horizontally fix this. And again, it's just one in front and one behind that haptic through the bag. Okay, so you can do this with minimal invasion to the anterior chamber, just 2 pericentesis, and you will be able to do the entire surgery. And I'm just making sure, I'm so scared to retract the iris because it's really peripheral anterior synechia, and it's really tattered and it's sutured. So I'm just making sure that I've come through the right site. I can hold the lens with my bag, with the lens forceps, so that I can make sure that everything is in right position. And again, we're doing the same procedure, one behind the haptic, the other in front. And I think you've seen the rest of the surgery is just like the rest. We would just tie 2 on 1, center the IOL, and at the end you have a very good outcome. So just my summary slide now. Very important, clear vitreous when it presents. Plan the site of fixation before creating the Hoffman pockets. Half scleral thickness to cover the Gore-Tex knot to prevent exposure, erosion, and infection. Ensure polypropylene flanges are buried in the sclera if you use the Cana Brava technique, and you need an optimal tension on the suture to center the IOL. Thank you very much.
Thank you, Professor Chee. Just one question while Dr. Jodhbir kind of sets up his presentation. One question would be, when would you not do sutures, and what kind of cases would you avoid sutures in these cases?
I really think that sutures in this manner actually are very, very minimally invasive. If I don't even have conjunctiva to play with, right, sometimes it's all necrotic and so on, or it's scarred from previous surgery, then I would use Cana Brava's technique so that you don't have to dissect anything at all. Yeah.